Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing about very high yield topic and very important in our medical field, because most commonly we can see this type of pathological condition in orthopedic. So today our topic is osteomyelitis. Okay, so in this osteomyelitis we are going to we are going to discuss about like basic to advanced stage. Like in this video we are covering the definition and pathophysiology and some classification types and some causative organisms and some imaging and management complications and some like surgical aspects also. Okay, so everything about osteomyelitis we are covering in this video. Okay, so watch till last, and if you have any doubts you can ask in comment section. So what is osteomyelitis? Osteomyelitis is an infection. First we have to break the if you are breaking that name, osteo means bone, myelitis means inflammation. That means the infection of bone and bone marrow leading to inflammation or destruction and necrosis. So it can cause osteomyelitis. So infection will be in bone and bone marrow and usually caused by some bacteria or less commonly by fungi and mycobacteria. Okay, if you are seeing this image, in this image you can see this bone, this vertebra. Inside the vertebrae, because of that infection, here it will make some space, then that space will form like some bacterial and it will spread. Okay, it's maybe because of that infection, maybe because of hematogenous or contiguous spreading or direct inoculation or like trauma or surgery. Okay, this osteomyelitis will be like acute or chronic or subacute, and we can see like pyogenic versus like tuberculosis. Everything we are going to discuss in this video. So etiology means causes. Common organisms we can see in osteomyelitis. Mostly first in neonates we can see like Staph aureus and E. coli and group B streptococcus. Okay, this is the most pyogenic osteomyelitis causative organisms. In neonates we can see Staph aureus and E. coli and GBS. In children same to same Staph aureus but MRSA and Klebsiella kingi. In adults Staph aureus and Pseudomonas, especially if any patient using like drug users, like they are using drugs like heroin and these things through needle injection or puncture wounds, these adults can get osteomyelitis because of this Pseudomonas or Staph aureus. And if any patient have sickle cell disease, they are very prone to get salmonella causative organism will cause osteomyelitis. Okay, salmonella very important. Next, in diabetes mostly polymicrobial like anaerobes or Pseudomonas. So it can cause diabetic foot. In diabetic foot also we can see sometimes this type of osteomyelitis conditions. Okay, so next sometimes you can see like okay, sometimes you can see the tuberculosis also. Tuberculosis, osteomyelitis because of mycobacterium tuberculosis. Okay, most commonly affects on spine. So this is the image you can see here. I already explained this image. Okay, so here in spine, if any osteomyelitis happening or in a hip or in knee, if anything happened this osteomyelitis in spine, then we can call that is Pott's disease. Pott's disease or TB, tuberculosis in spine, like that also we can tell that thing. In Pott's disease, because of this infection causing inside the vertebra disc or vertebra, then it will cause some space. Because of that space, that area will get some empty space. Because of that empty space, the total body weight will get compressed. Because of the compression, the patient can get scoliosis also. Okay, so when we are discussing about that POTS disease, that time I will go little deep. So now I am just giving that brief explanation about POTS disease. Okay, next, pathophysiology. In pathophysiology, first we have some roots of infection. How? Hematogenous, it's most common we can see in children, and some mostly in metaphysis of long bones. In long bones we can see in metaphysis area. Okay, and sometimes like contiguous spread, like post trauma, that means after getting some trauma or surgery or diabetic foot ulcers can cause this type of osteomyelitis. Or direct inoculation, like open fracture or orthopedic implants, these things can cause also osteomyelitis. Okay, how? First, the bacterial seeding. How that bacterial seeding happening means, if bacteria enter into bone via bloodstream. Okay, maybe because of bloodstream or trauma or some adjacent infections. Okay, when that bacteria is enters into the bloodstream or trauma and adjacent infections, then the body will release some inflammatory response. That inflammatory response can cause pus formation. Okay, so when we are getting inflammatory response, then pus formation will happen. This pus will increases some intraosseous pressure. Okay, so that pus pressure because of that that pus pressure, then it will compromise the blood supply. Whenever that our body not getting blood supply properly, then it will cause ischemic. Because of that ischemic, we can see bone necrosis. Okay, after bone necrosis, we can see the sequestrum. Sequestrum means simple, that is the bone necrosis we call sequestrum. Okay, then body forms some new bone over necrotic bone. Okay, if whenever that because of that bone necrosis, then body will form that new bones that we call involucrum. Okay, in bones we have one in bone we have one thing, that is like if any bone getting stress, so that stress, because of the stress, that bone will increase the strength. Okay, so here because of that pus, vascular compromise will happen. Because of vascular compromise, because of ischemic condition, the part will get necrosis. That necrosis we call sequestrum. That's because of the sequestrum we can see new bone formation, that thing we call involucrum. Okay, in chronic infection, it persists due to poor antibiotic penetrating and necrotic tissue. Okay, if you are seeing this image, you can see here, this is the normal bone. That because of if you are seeing this image, you can see everything like step by step. First of all, the bacteria enters into the bone because of the bloodstream, then trauma or adjacent infection, then we saw some inflammatory response, then here pus formation happen. After pus formation, the pus will compromise the blood supply and we can see some bone necrosis. That bone necrosis we call dead bone or sequestrum, and it forms abscess. Okay, so after abscess, that boning, that body forms some this extension into superficial location. Because of that necrotic tissue, we can see some extension into some part going to joint cavity, and some extension also we are seeing in subperiosteal location. Okay, then after we can see in next stage, that new bone formation will happen in sides of the bone. Okay, then finally sinus tract, and it will spread, and with spreading, and it will cause that spreading osteomyelitis. Okay, So mostly in bone, first of all we have to understand before going to osteomyelitis, we have to know the anatomy. In anatomy, mostly this osteomyelitis mostly happens in periosteum, like outer fibrous layer and inner osteogenic layer, and rich blood supply and nerves source of pain in osteomyelitis. Mostly in cortex. In cortex, you can see like dense outer bone. That infection can compromise the nutrient vessels. If you are seeing the medullary cavity, if inside the bone intramedullary, that medullary cavity contains some bone marrow, that bacteria often lodge here first. Okay, so I think we have some, we know the Haversian and Walkman canal. It helps in the spread of infection within the bone to another bone. Okay, when you are seeing the metaphysis in long bones, especially in children, it's like highly vascular with sluggish blood flow and making it prone to bacterial seeding. Okay, and sometimes that phagocytes also act like fever, and it's like it will supports the bacterial growth. Okay, so this is the how the bone how that infection will spread. Okay, next, types of osteomyelitis. Total we have three types. First one, acute. In acute, like less than 2 weeks, and systemic signs we can see in that osteomyelitis, and localized pain, and you can see some swellings also. Okay, when it's coming to subacute, in subacute osteomyelitis we can see the Brody abscess. Brody abscess means in metaphysis area some pus will happen, and that it will cause some space. In that, if you are doing any MRI or in X-ray, you can see this type of image. Okay, some circle type image, oval shape. Okay, and this infection will cause that Brody abscess. Then after the bone will get delicate and that bone will break. Okay, so next, in subacute we can see some mild symptoms. In chronic osteomyelitis we can see greater than 6 weeks, and sinus tract, sequestrum, involucrum, and minimal fever also. Okay, next, what are the clinical features? In clinical features, first one, in mostly first in local. In local we can see fever. In local we can see some pain, swelling and erythema, warmth sensation, tenderness, and decreased movements or decreased range of motion. In systemic clinical features, we can see fever and malaise, like chills, with pains, like often it's mostly absent in chronic cases. In chronic osteomyelitis, like draining sinus tracts and non-healing ulcers also we can see in chronic thing, and some pus discharging, and like bone deformity and restricted movements. This type of things we can see in clinical features of osteomyelitis. Okay, now how we can diagnose the osteomyelitis means, first of all we can do the laboratory tests like CBC. In CBC we are checking like increasing blood cells like leukocytes. Next one, we can check C-reactive protein and erythrocyte sedimentation rate, because erythrocyte sedimentation rate is like very important for this erythrocyte sedimentation rate is more useful for monitoring the inflammation and infection things. And we can do some blood culture, because in blood culture we can easily understand the positive of hematogenous cases. Okay, or hematogenous spreading. Okay, and we can do some bone biopsy. This bone biopsy culture is very like gold standard for causative organisms. Based on that organism we can start antibiotic or management of the osteomyelitis. Okay, next, in imaging. In imaging, what are the things we can see? In X-ray mostly we can see the changes seen after 10 to 14 days, like periosteal reaction or bone lysis, breakdown of the bone, like lytic areas and these things. And mostly in X-ray, if you are seeing this image, first image, you can see involucrum. What I said, involucrum means some new bone formation. If you are seeing this area, that bone got bulge, it increased that area. Okay, in sequestration, what we call, if any bone is breaking, if any bone getting like necrosis and it's breaking means, then we call that is sequestrum. If you are seeing this image properly, you can see some circle type necrosis thing. Okay, this is X-ray image. Next one, in X-ray we can see some Brody's abscess also. This area, this is Brody's abscess, and this area, this is also Brody's abscess, and some lytic area also. Lytic means that bone getting breakdown. Okay, or bone breakdown or periosteal reactions we can see in this X-ray. Okay, so in X-ray, what are the things we observed? First one, lytic area means bone breakdown, and periosteal elevation, or we can tell periosteal reaction, or sequestration, that means necrotic tissue, necrotic bone tissue, necrotic bone. And involucrum means we can see after 10 to we can see these changes in after 10 to 14 days of the osteomyelitis. When you are seeing when you are doing the MRI scan, we can, this is very best initial test for detection of the edema. If any patient have, because of osteomyelitis, if any patient have edema, then we can see edema in MRI scan. Okay, you can see this image. This is the MRI of the osteomyelitis of distal part of the femur bone. Okay, so this MRI will increase the sensitivity for acute stage within 3 to 5 days. Okay, so MRI is the best early detection for osteomyelitis, and we can see some marrow this bone marrow edema also. Okay, next, in CT scan, CT scan is very good for cortical involvement and sequestration, and like before surgery planning, we have to do CT scan, and we can finalize the and surgical management and these things. Okay, next one, bone scan, or we can tell bone scan, or we can do PET scan also, or no, bone scan or PET CT also. Okay, sorry. For difficult or hidden sites, we can easily find out with bone scan. It's very sensitive, but not the specific. And we can, I already mentioned biopsy, and we can do culture also. Okay, so next we are going to do management. How we can manage this osteomyelitis? First of all, that management also is divided into two types, like acute osteomyelitis and chronic osteomyelitis. In acute osteomyelitis, first of all, we have to start with empiric intravenous antibiotics. In neonates, like vancomycin is the most common for every age. So in neonates, vancomycin, and we can start with third generation of the cephalosporin, cefotaxime. In child, vancomycin plus cefazolin, oxazolin, or MSSA, because of MSSA coverage. Okay, next one, in adult, vancomycin we can use, and cefepime we can consider like MRSA and gram negative, and we can do intravenous drug users like vancomycin and ceftazidime and cefepime, and we can because we can do coverage of the pseudomonas. In duration, mostly we can use this antibiotic for intravenously 4 to 6 weeks, and it can transition to oral, or if improving organism is identified. Okay, next, in surgical second one, we can do surgical drainage or debridement. If you are seeing any that pus conditions or no response, if that antibiotic is not working and the body is not reacting with antibiotic, then we have to do surgical drainage, or neurological, we have to check any neurological compromise is there or not. In spine, then we have to do surgery, and we have to check with for joint involvement also. Next, in chronic osteomyelitis, what are the things we have to do? In chronic osteomyelitis, first of all, we have to do surgical debridement. In surgical debridement, we have to removal of sequestrum and necrotic bone. Okay, next one, long term culture or specific antibiotics. Based on culture we have to start specific antibiotics, like I already mentioned, intravenously we have to give for 4 to 6 weeks. If oral that patient is can take, means we can start with oral suppressive therapy. Okay, next one, we can do reconstruction. In reconstruction options we can start with antibiotics and impregnant cement beads, and we can do bone grafting and flap coverage if soft tissue is lost. Okay, next, in classification, total we have two types of classification in osteomyelitis. First one, Waldvogel classification. In Waldvogel classification, first of all, it's based on origin. Okay, total we have three types of triad in osteomyelitis. First one, acute homogeneous osteomyelitis, and what means that that infection is occurs via bacterial transport in blood, then after account for majority osteomyelitis in children under 5. Hematogenous means that infection is spreading by that infection is entering into bloodstream and it will cause the osteomyelitis. This condition we call hematogenous. Okay, under 5 years. Next, contiguous. The contiguous means the spread from trauma and surgical site. If any surgeries happened or any trauma happened, then this contiguous, like adjacent tissue allowing bacterial inoculation, like post traumatic, open wound, joint replacement and prosthetics. It can cause the osteomyelitis. So this is the second one. In third one, that is disruption of blood supply. Disruption of blood supply means like it will comes in chronic, like associated with vascular insufficiency, like diabetic patients with foot infection or peripheral vascular disease. Okay, so these are the things. So in Waldvogel classification we saw three things, that is first one, hematogenous. Hematogenous will be like because of that infection, that bacteria is entering into the bloodstream. Second one, contiguous or focus. In contiguous, mostly like bacterial inoculation because of post traumatic, open wound or joint replacement or prosthetics. Third one, like chronic, like associated with vascular insufficiency, like diabetic patients with foot infections or peripheral vascular diseases. When it's coming to second classification, we can see the Cierney-Maeder classification. It's mostly based on anatomical and physiological states. Total we have 4 stages. In first stage we can see medulla. If you are cutting the bone, like for example femur bone, into cross section, then you can see this type of image. In this type of image you can see this is the cortex and this is the medulla. In this medulla, if any, like you can see inflammation or infection of the bone or bone marrow, then it will comes in stage 1. It's like in Cierney-Maeder classification, this is stage 1 osteomyelitis. Okay, in stage 2, superficial, that means the upper part of the bone will get the infection. Okay, so inflammation, so it will comes in stage 2. In stage 3, localized, so total like superficial and medullary part will comes, so it will we call stage 3, that one localized. In stage 4, like diffuse, that means like cortex and this medullary part and that periosteum, everything will get infection. Okay, it's this stages is based on consider host factors, based on that infection, based on causative organisms. Okay, are A, B, C, and we have some for host factors also. Based on that we can classify we can give name to the stage, and based on that thing we can do management. And we have some special conditions. The special conditions like diabetic foot. If any diabetic foot osteomyelitis, that is like because of polymicrobial or contiguous spreadings, we can do treatment like debridement. Debridement means that a necrotic tissue or that death tissue we are going to scratch and we have to remove. That condition we call debridement, and we have to start with broad spectrum coverage also. Next one, if you are seeing we are seeing the vertebral osteomyelitis. In vertebral osteomyelitis, I already told we call that is the POTS syndrome or POTS disease. Okay, that means like a spinal TB. Okay, or you can tell vertebral osteomyelitis, like we can see in this patient back pain and with or without a neuro deficit. Okay, and we can see some MRI. For this thing, MRI is the very best option to diagnose, and for treatment we have to do biopsy for ruling out the malignancy things, and we have to start antibiotic, and we have to do surgery if patient is unstable, or if patient have abscess, then we have to do surgery. Next one, sickle cell osteomyelitis. In sickle cell, mostly the main causative organism is the salmonella. This is very important and golden point for your exams. So we can do treatment for this sickle cell osteomyelitis, like we can add fluoroquinolones and the third generation of cephalosporins. Okay, now surgical principles. What are the surgical things we can use? We can do debridement. I already mentioned, removing the death tissue or necrotic tissue, we call debridement, to bleeding bone, and we can see some paprika sign. Now paprika sign means, if you are seeing this image, you can appreciate that from that bone we can see the bleeding, this area. So this part we call paprika. Okay, this is the living bone. This is the after debridement, that means after that part died, then it will release some we can see some bleeding of the bone. That sign we call paprika sign. And you can see some dead space management, like we can start with local antibiotic and muscle flap. And stabilization, we have to do stabilization if structural instability if we are seeing means, then we have to do stabilization. Next, we have to reconstruct the constructive options, like we can do reconstructive options like bone transport. In bone transport, mostly we have to focus on Lijarov also is like, it's for transporting the bone, and we can do vascular fibula grafting also. In complications, mostly we can see the chronic infection, sinus tract formation and pathological fractures, and growth arrest in children, and malignant transformation. In malignant transformation, like Marjolini's ulcers, because of that Marjolini's ulcers, that patient will get squamous cell carcinoma in chronic sinus tract. Okay, so these are the things we discussed osteomyelitis. Okay, so always if you are suspecting osteomyelitis, we have to do some labs, then MRI and blood culture, and we have to start with empiric antibiotics and biopsy, and if any abscess and any and patient is unstable means, then we have to do debridement if needed, and we have to culture directed therapy, and we have to always monitor the erythrocyte sedimentation rate and see reactive protein. Okay, so here I am going to give some tips. For early suspicion, we have to MRI for diagnosis, and we have to know the differentiate of the osteomyelitis, like acute and chronic, and so these are the things we covered everything in this osteomyelitis. If you have any doubts, you can ask me in comment section. Okay, so we will meet in our next video. So if you didn't subscribe my channel, like, share and subscribe. So we will meet in our next video. Take care. Bye bye.